would have prostate cancer and probably never knew it. So it is really considered an old man's disease. So we'll talk about that. So what is prostate cancer? You guys have probably heard a little bit about this before, or no. Obviously, cancer of the prostate. Sometimes it starts out as BPH, which you guys have heard about before, right? Benign prostatic hypertrophy. So you have an enlarged prostate gland, basically, that sometimes that can be an indication of prostate cancer, but the symptoms can be very, very similar for BPH and for prostate cancer. One doesn't necessarily mean it will lead to the other, but it can be a risk factor for people who have BPH, or males that have BPH. It's very curable when diagnosed early. You can see the 5-year survival rate is 100%. No other cancer has a 100% survival rate if caught early. If it's spread regionally, so meaning that just to some lymph nodes within the lower groin area or surrounding the prostate, it still has a 95% overall survival rate at 5 years. So this is not typically an aggressive cancer. People can live with this for usually till old age, and something else will take their life. It's not something that usually people die from. There is a little bit of mortality that happens with it, but not as common as some of your other cancers. So this just is a visual of what a normal prostate looks like, and then somebody who has BPH. So you can see this gland is very enlarged. So what sort of symptoms would they present with if this is what their prostate looks like, if they have BPH? What?
Difficulty urinating.
Yep, difficulties urinating. So they might have pain, they might have burning, they might have urgency or frequency. They might be more prone to developing UTIs if they get a lot of urine that just kind of sits here, or if they aren't able to fully empty their bladder. Pretty common. So yeah, just basically a change in their normal urinary habits. They might have nocturia where they're getting up frequently in the night to go to the bathroom, or they have to go more frequently. So the exact cause really is unknown. They believe that it's hormone related, so that this is caused from androgens, which is hormones that males have within the testicles that feed this cancer. But also it's considered, again, old man disease. So usually people over 65 is when they're diagnosed, and they don't have as many of these hormones fluctuating in their body. So again, the cause really is unknown. Almost all prostate cancers are adenocarcinomas, just means that's the cell that it originates from. Pretty common. They tend to develop in the peripheral zones of the prostate gland, so more towards the outside. They sometimes can compress the urethra, which makes sense why they would have changes in urinary function, right? If you have pressure on there, they might have pain when they urinate, have frequency. A lot of times they are not able to fully empty their bladder, so they're going more common. It metastasizes just like other cancers through the lymphatic system, through the blood system, through blood and lymph. Where do you think it's most likely to metastasize to, if you had to guess?
Bladder.
Not necessarily the bladder. What did you say, Carter? Got it. Any other guesses? No?
Groin.
Sometimes the lymph nodes within the groin. Bones is usually the #1 place that prostate cancer will metastasize to, is the bones. And sometimes that will be their first symptom. So depending on where their tumor is, if it's not kind of near the urethra, or if it's not pressing into the bladder, if it's more on the outer edge, they might not have a lot of urinary changes. And if it spreads and metastasizes, they might start to have like lower back pain. Very common area for it to metastasize is to the spine. So obviously men get this. 1 in 9 will be diagnosed. If they're over 80, I think the statistic actually goes up. So a lot of males will get this. Not a lot of deaths. So again, it's a pretty curable disease. So old man disease. Some other risk factors, genetic and hereditary. So if somebody's grandpa had it, dad had it, guess what? You're probably gonna get it. There has been a BRCA gene linked to prostate cancer, believe it or not. So just like the breast cancer gene can have that BRCA gene on there, there has been prostate cancers that have found a BRCA gene. So they're starting to see some new genetic links for prostate cancer, especially in men that are diagnosed younger, because really this is an old man's disease. Males who've had a vasectomy, so they no longer want to have babies, they get a vasectomy, kind of changes their hormones a little bit, puts them at higher risk of developing prostate cancer. There's also been studies out there that firefighters, because of the chemical exposure that they're exposed to, it actually puts them at higher risk of developing prostate cancer. I don't know how true that statement is, but your book says that. And then if they have an STD or have had an STD at some point in their life, which makes sense, that would disrupt the cells there, right? So if you think about metaplasia, dysplasia that we talked about day one, that could potentially put them at higher risk. But truly, it's just being older age, they're at risk for developing prostate cancer. So how can we prevent it? Some of those things, if they know there's chemical exposure, or if they do have a hereditary link, if their dad had it, grandpa had it, multiple people, males in the family had it, they might want to start screening a little bit earlier. So how do you think we screen for prostate cancer?
PSA.
PSA, yep. So you guys know this stuff. So they draw a blood test, PSA. It's not always 100% accurate for prostate cancer, because sometimes if you have BPH, it can kind of cause a false positive PSA as well, but they still use it. They also use digital rectal exams, so turn and cough, where they stick their finger up someone's rectum and feel for the prostate to see if there's enlargement there. They can also do, if they have any changes in their urinary stuff, then they can start to do ultrasounds or start to look and see, okay, is there something going on? There's two medications, dutasteride and finasteride, that have been shown to actually reduce the risk. The problem is they have a lot of side effects. They can cause changes in their urine, they can cause erectile dysfunction. So typically men don't want to be prescribed these because of the side effects. They'd rather just take the risk of getting prostate cancer. There is an ethnic risk. African Americans are more prone to getting this at a younger age. They're not really sure what the correlation of that is, but research is showing that they tend to sometimes get it at a younger age. Often people are asymptomatic, so it doesn't present with any symptoms until it gets worse, but again, still has a good prognosis. We already talked, it usually goes to the bone, so sometimes bone pain will be their first symptom that they have. Changes in urination is a big one. Sometimes they'll have bloody discharge with urination or ejaculation. So believe it or not, old men are still sexually active. So your parents, probably grandparents, might have this issue. You can talk to them. Do they have any bloody discharge with ejaculation? We don't have that conversation. So screening and surveillance is important. Obviously, any changes in urination is going to be the first sign. So how they're going to diagnose it, so DRE, digital rectal exam. So again, turn and cough. So feeling, does the prostate feel enlarged? If it does and they have an elevated PSA, then they will go in and do a biopsy typically to take a sample of the prostate. So men, you can imagine how painful that probably is to go in and take a sampling of the prostate gland. They can also do an ultrasound transrectal, so they put a probe up into the rectum and take a look through ultrasound of the prostate to see if there's any nodules, any lumps or bumps there. They can do sometimes a urinalysis to see. There's new tests that are becoming available to screen for this and also to see if they're at higher risk for getting prostate cancer. They can test the cells around there. They'll usually do a bone scan to see if there's any involvement within the bones, or what lab would they test. If somebody came in with a lot of bone pain, what might they draw? What were you gonna say, Taylor? Calcium, right? Because if you have cancer in your bones, then your bones are going to dump calcium into the bloodstream as those bones become broken down, okay? So they might have hypercalcemia. So they stage prostate cancer by the grade. So that's kind of this cell differentiation. So if you look at it under a microscope, how well differentiated, moderately differentiated, or poorly differentiated, that's kind of blurry. But basically, does that cell look pretty close to a prostate cell? Then it's more well differentiated. That gives them a better prognosis and means that it's growing at a very slow rate. So the more poorly differentiated it is, probably the faster it's growing. Or they'll also use a Gleason score, which basically they score 1 through 5, and basically it's saying the same thing. So if you hear men talk about, oh, my Gleason score was 3, then you know, okay, 1 through 5, 5 being the highest, which means those cells are poorly differentiated. So they look the least amount like a normal prostate cell. Or their Gleason score is a 1, then they have probably a very, very slow growing prostate cancer. So they'll use Gleason score to stage it. Also, they'll stage 1 through 4, so if there's lymph node involvement, the tumor size, just like they stage other cancers. Again, not something you guys need to know, but you might hear people who have prostate cancer talk about their Gleason score, and they'll use that kind of as a factor too to determine if they need to get treatment. So a lot of times if they have a very low Gleason score, they won't do any treatment. They'll just watch and wait. And we'll talk about that in a little bit. So they can have surgery where they can have a prostatectomy, where they have the whole entire prostate removed. So if that happens, they tend to have a lot of side effects, and one of those being erectile dysfunction. So a lot of times if they have a low Gleason score, they don't have a very aggressive tumor, it's not really invaded into other lymph nodes, they'll just choose to watch and wait, because if they do any treatment, it usually causes them way more side effects than doing nothing. And because this is such a slow growing cancer, a lot of times they choose not to do anything. So my dad was actually diagnosed with prostate cancer 3 years ago. My grandpa had it when he was in his 70s. My dad is 70 and was diagnosed at 68. So my parents lived 7 hours away, western Nebraska, and when they would drive up here, he'd have to stop about every 45 minutes on the side of the road to go to the bathroom, to pee. So then he knew, okay, I got the prostate cancer. Like, he just knew. His dad had it. Why else would you all of a sudden have all this urgency where you have to stop and go to the bathroom all the time? They are literally doing nothing, watching and waiting, because he has a very low grade. His Gleason score is very low. He doesn't have any lymph node involvement. There is one area that is very close to a nerve, which they watch closely, because that is concerning that it could potentially spread, but he has no other symptoms. And so for 3 years, they've done nothing. He just lives with this in his body. And for some people, that can be very hard. My mom had a hard time with that for a while, like, shouldn't he have it removed? Don't they need to do something, right? We are a society of, if there's a problem, we need to treat it and fix it right now, right? In Western medicine, that's kind of how we think and act. So for a lot of people, that's really hard to just watch and wait. But sometimes the treatment and the side effects is way worse than just watching and waiting, because it might not ever advance into anything more. It's basically like having BPH for the rest of his life, okay? But they can do surgery. So if they do, what would be some surgical considerations? Obviously monitor their urinary output, right away. Are they able to urinate after? Do they have any bleeding? Do they have any clotting in there? And then you have to do some education on erectile dysfunction, which really is, with people with prostate cancer, kind of the elephant in the room, because what nurse wants to talk to a 7-year-old man about erectile dysfunction, right? But sometimes that is very hard for men to accept. It's part of their manhood to be able to get an erection whether they're sexually active or not. And they can also have a lot of incontinence or leakage if they have surgery or go through treatment. So some will choose just the watch and wait method. They have new surgeries where they can do it robotic. They still will have similar side effects though. So if males do have surgery and are having a lot of these, we can educate them on like doing Kegel exercises to try to strengthen their bladder and try to strengthen that urethra after that prostate's been removed to try to help with the incontinence. They can have, some men will get like a penis pump, that is a real thing, where they can basically give themselves an erection at any point with just a pump. But usually when they do a prostatectomy, the nerves are removed, so they don't get the same sensation, the same feeling. So a lot of men will choose not to do that. Again, personal preference. They can treat it with hormonal agents. Again, there is some hormone that will feed this cancer, so they can, just like for breast cancer, what Nolvadex or tamoxifen blocks hormones. They can give a med called anti-androgen therapy. It does the same thing. It blocks those androgens that are potentially feeding that, known as Casodex is a very common one, or Lupron or Luprolide. This is an actual injection that they get once a month, and it basically blocks those androgens or hormones that potentially are feeding this cancer. So usually that's what they'll use for treatment. If we stop male hormones, what are some signs and symptoms you think might happen to that male? They might have voice changes. They can potentially get gynecomastia, so that's where they grow some breast tissue. They can have hot flashes. So just like females, if you block their hormones, they can have hot flashes, so can men. It can cause some fatigue, some kind of achiness. So there is some side effects to these. Sometimes they'll give them meds with estrogen in them to treat it, but if they have any sort of cardiac risk, it will elevate that. So you have to kind of know, okay, have they ever had a heart attack before or any sort of cardiac risk. My dad had a heart attack when he was in his 40s, and so he doesn't take any sort of hormones for that reason, because the risk is actually higher to put him on hormones than just letting this prostate cancer just kind of sit there. They can also do radiation therapy. So when you guys are at the cancer center, I guarantee there will be some people there getting treatment to the prostate. So this can be an alternative to surgery. They usually do 5 to 6 weeks of radiation treatment where they'll just go and shrink the prostate. So sometimes they'll do this if they're having a lot of symptoms, or if their PSA is going up and continues to go up over time, then sometimes they'll recommend radiation therapy over surgery. It can still cause some of the same signs and symptoms or side effects, so they can still have some erectile dysfunction, not as bad as surgery, because the prostate is still there. They're just shrinking or trying to get rid of the tumor that's sitting in there. So a little less side effects with radiation, but they have to be able to come and go to treatment every day. They really don't have a lot of skin breakdown when they're treating the prostate. They can have some GI side effects with radiation, depending if they get a little radiation to the abdomen area. It can cause a little bit of diarrhea. Usually the biggest side effect they have is fatigue. They can also do interstitial implants or seeds. So this is kind of old, I don't want to say old school, but years and years ago, this is how it was kind of the standard of care. If anyone had prostate cancer, they would actually inject these little seeds up into the prostate, and then they would be radioactive and it would dissolve that tumor. So there was seeds implanted up in there, but that person would be radioactive for a couple days, and so they would either have to be in the hospital or have to stay in a hotel room away from their family. They usually don't use radioactive seeds or implants anymore, just because external beam radiation is a lot safer and just as effective for prognosis wise. So they don't usually use it. If they do have an implant and they're in the hospital setting and that implant falls out, what do you think you would do as the nurse? It's radioactive. NCLEX loves this question. I've seen it 1,000 times, so this is why I bring it up. So if somebody has, they can also do this for like female cancers like ovarian, where sometimes they'll put in a radioactive implant. So typically they would have like a vest or a shield for the nurse to wear who's taking care of that patient, so you're not exposed to radiation. And they would have like what looked like tongs or some forceps that you could potentially pick up that implant and put it on a lead disposable pad and then call the radiation therapist or the radiation doctor, and they would dispose of that properly, or the hospital would have a protocol of how to dispose of that implant without exposing anyone else to radiation. Okay, so if you ever see NCLEX question, an implant falls out, you use the forceps, you put it on a lead towel or lead drape, and they dispose of it. They have a protocol in their system to get rid of it. So kind of an old way of treating prostate cancer. Or they can use high dose radiation. We talked about this with radiation, where they get 2 treatments, very high dose. So they get one in the morning. They have to sit kind of in the stirrups with these probes or catheters in the prostate, and they give a high dose of radiation. They usually wait about 12 hours, give another high dose, and then the patient goes home. So if somebody, they'll use that a lot of times, like if somebody has to travel a long distance, or if they don't have maybe transportation, or they don't have a support system that can bring them to radiation every day, and maybe they're not a good candidate to have surgery done, or they don't want to have surgery, then sometimes they'll do high dose radiation because it's done in one day and then they're done. Make sense? Some alternative therapy. So there's a lot of controversy out there that certain dairy products, processed meat, can actually increase people's risk of developing prostate cancer, or really any cancer. I don't know if that's 100% true, but also if they take vitamin E or an aspirin, there's some research that says that that prevents prostate cancer, although there's some conflicting research that vitamin E can lead to it too. So I wouldn't take a lot of clout with that. So they can do digital rectal exam, assess for bladder distension, assess do they have any changes in their urinary habits, urinary retention, urinary frequency, do they have bone pain. Assess the degree of incontinence and effect on their lifestyle. So for some men to be incontinent can be very embarrassing, especially if they have to wear like a diaper or a pad or something. That can be very embarrassing to an older male, right? So teach them Kegel exercises. They have some newer therapies out there that they can do for rehab to kind of help strengthen their bladder, to help prevent with that. Surgical treatment can cause erectile dysfunction. That can be very hard for men to have, and some will choose not to have surgery for that exact reason. So provide the opportunity for the client and the partner to discuss their options and be openly about those. They can try medications like Cialis for erectile dysfunction, Viagra, those kind of meds. Sometimes they work and sometimes they don't, so they have to have those hard conversations. Discuss medical and surgical treatments for ED, refer for sexual counseling as appropriate. So an oncologic emergency with prostate cancer can be spinal cord compression. So if they do have more of an aggressive form, or if it is an advanced stage and they have a very large tumor sitting on their spinal cord, usually it's in the lower area, like lumbar spine, or even sitting more in their pelvis area. And if they have a sudden loss of bowel or bladder function, or a sudden onset of numbness and tingling, this potentially could cause long-term paralysis if it's not reversed right away. So they're going to do radiation, high doses of radiation, to that tumor that's sitting right on the spine to try to relieve the pressure off that nerve. They'll sometimes put them on steroids, high doses of steroids, to try to reduce the inflammation. They typically won't go in and do surgery just because of the recovery, and there's some more complications with surgery versus just doing radiation. So that's really our biggest oncologic emergency with these patients. Then similarly, cancer survivor. So that's the end of the nitty gritty of prostate cancer. Old man's disease, it can be treated with hormone therapy. If so, they can have hot flashes, they can grow breast tissue. Erectile dysfunction is a big thing, so talk to them about that, or make sure they have a good understanding of that is a complication of the treatment. A lot of times they watch and wait. That's prostate cancer.